Madam, we are live now and we are starting the program. So good evening, doctors and all the participants. Shumon, on behalf of Shield Healthcare, welcome you all in today's session and very important session, that is management of dysmenorrhea, and itself it's a very common session. And our guest speaker is Dr. Kumudini Jha Madam, and it's our honor to introduce Madam. Madam is a senior obstetrician and gynecologist. Madam did her MD PhD from Darbhanga Medical College and DNB. Madam was the ex-head of the department at DMCH, and in terms of academic activities, Madam presented many papers in national and international journals. She is a speaker in several CMEs, conducted several seminars, webinars, and presented several papers in many state and national conferences. And Madam was the examiner of undergraduate and postgraduate candidates, and Madam was the clinical secretary of the Darbhanga Obstetrics and Gynecological Society. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please drop your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, for your valuable time once again to discuss on this very important topic, dysmenorrhea, on our platform Shield Connect. So thank you, and over to you, ma'am, for further proceedings. Thank you very much.
Thank you so much, Suman. That's very nice of you, and I thank Shield to invite me to talk on this very important topic of dysmenorrhea in pregnancy. We all know it is almost one of the commonest symptoms that we face in our practice every day, be it in the hospital or in the private clinic. So now we'll be discussing about it. And can I please have the slides? We all know that dysmenorrhea can be of two types, basically, primary and secondary. Primary, when it starts right from the menarche, and the cause is usually not known for that. But there are, the secondary dysmenorrhea does have causes. And now we'll see how we can you have, right, the first two slides. So dysmenorrhea means what? This means pain. And the pain that occurs during menstruation is called dysmenorrhea. Now the period of pain can be, that may be a low abdominal pain referring to the back with cramps in the legs, and the onset usually occurs in adolescence. It occurs at or shortly after 6 to 24 months of menarche, in the first period, that is, and the onset of pain usually has a clear and predictable temporal pattern. The pain begins just before or at the start of menstruation. Pain is most severe during the first or the second day of menstruation. Next slide, please. Next slide, please. So it is usually associated with additional symptoms like nausea, vomiting, diarrhea, or constipation, headache and dizziness. And it may be quite painful for the patient, because many of these girls, young girls, they have to leave school because of this. They feel fatigued. There is insomnia, loss of sleep at night, and there's a feeling of bloating. This is a very common symptom. Breast tenderness is very common even among the patients of secondary dysmenorrhea or in the premenstrual syndrome that we have. Mood changes like anxiety, irritation, and depression, and there is loss of libido. In the patients who have their husbands and family, their family life is disrupted for these few periods, the days of the month, because the patient becomes very irritable, and they may not respond well with their family members. So you can see these symptoms affect the family life also and the social life as well. Next slide, please. So what is the impact of dysmenorrhea? There's absenteeism from school. We have seen patients who just writhe in pain, and they dread the time when the menstruation is to come. Loss of work days, absenteeism is there, decreased work efficiency, and decreased focus on studies. So this harms their curriculum also. And in the government setup also, we have special leave for 2 days just because of these menstrual problems. There's reduced sleep quality, physical activity, there's poor mood, anxiety, stress when in pain, and it affects the quality of life and the performance in daily life activities in women. The rates of absenteeism in these women range from 34 to 50%, losing 1 to 2 working days per month. And this amounts to an annual loss of approximately 600 million working hours. So this may amount to around $2 billion annually in the USA. It is just because of this is the impact of dysmenorrhea. Next slide, please. So what is the prevalence? The prevalence estimates vary between 45 and 95% of menstruating women, especially when the children see that their sisters or the mother has this problem. So then they are also tuned to it, that this happens and this is normal. So that is one of the factors also, that if they see the sister and mother in dysmenorrhea, then even if they have a cause or not, that psychologically builds up to it. Severe primary dysmenorrhea is estimated to affect 25% of women. As such, dysmenorrhea appears to be the most common gynecological disorder in women, irrespective of nationality and age. Next slide, please. So what are the types of dysmenorrhea? They could be primary and secondary. Primary, the typical age range of primary dysmenorrhea is between 17 and 22 years of age. And the secondary dysmenorrhea is more common in older women, that is, say, in the reproductive age group, because the causes that we'll see later, they are usually found in that age group. Next slide, please. So what are the causes? The exact cause of dysmenorrhea is not completely understood, and it may possibly include multiple factors with unexplained mechanisms. But forceful or excessive uterine contractility during menstruation in women without pain, the uterine pressure is in a minimal of 10 millimeters of mercury, and it is elevated in women with pain to more than 120 millimeters of mercury. So there's quite a big difference. And the increased number of contractions per 10 minutes, that is usually more than 4 to 5, and non-rhythmic uterine contractions in women with pain, like in labor pains, in false labor pain and in true labor pains. There's a difference in the magnitude of the pain. Intrauterine pressure is estimated. So there's in false pain, you do not have the rise in pressure to that extent, like when the patient is in the second stage of labor, then it can go up to 100. So excessive synthesis of prostaglandins. Now this is one of the basic mechanisms. Why what happens in normal menstruation? In normal menstruation, usually we see the estrogen and progesterone that rises under the effect of post FSH, and then the estrogen that induces the LH receptors, and LH is stimulated. That causes the ripening of the follicle, and again that causes ovulation, leading to the release of progesterone. Now, in anovulatory cycles, this does not happen. And when the corpus luteum is formed, then if there is a pregnancy, it continues, and then it leads to when the formation of the placenta occurs, then it takes over the function of the corpus luteum. But when there is no pregnancy, then there is atresia of the corpus luteum, and then there is the menstruation occurs. Now, that is because the support to the endometrium goes down under the effect of less amount of estrogen in the second half and progesterone withdrawal. And then you have the menstrual fluid. Now, what is the menstrual fluid? That contains blood, WBCs, and sometimes a membrane that is shed from the endometrium. Now, why is the blood usually fluid and it does not clot? Unless there is excessive amount of bleeding, which cannot be handled by the fibrinolysin mechanism. So there is, during menstruation, we have the prostaglandins, various types. You know that there are prostaglandin F2, which causes contractions, which are higher in these patients of dysmenorrhea. And you have the thrombocyclin and the prostacyclin ratio that is disturbed. The thromboxane is higher than the prostacyclin. The prostacyclin, usually PGI2, causes vasodilatation, and so there is no ischemia. But when the thromboxane is high, there is blockage of the vessels, and the prostaglandin F2 when it is high, it causes severe contractions, and we know that it will cause ischemia, hypoxia, and the ischemia, like you have the pain of claudication. So this is the pain, the cry of the uterine muscles. So there is excessive synthesis of prostaglandins in the patients of dysmenorrhea, and disturbances or decrease in the uterine blood flow. This reduced uterine blood flow during contractions leads to hypoxia and thus causes pain. Next slide, please. So this is the pathophysiology. The women with dysmenorrhea have excess amount of prostaglandins. Excess of prostaglandins will cause forceful uterine contractions causing pain, and forceful uterine contractions will cause decreased blood supply like after delivery. We know that if there are good uterine contractions, the bleeding stops because there are these muscle fibers, they act as living ligatures, and in between the interlaced fibers are the blood vessels. So that leads to ischemia to the uterine muscles and myometrium. Ischemia will further increase the pain. Next slide, please. So there are the how to diagnose primary from the secondary dysmenorrhea. So basically, we should begin with the history, and we know that it happens on the first day of menstruation, lasts for the it is maximum the pain scale. On the pain scale, it is maximum on the first 2 days. So if there are no previous diagnosis of pelvic pathology, and it is menstruation associated leading to cramping and low abdominal pain, and we have seen that the radiation is usually towards the thighs and the back, then the onset usually occurs between 6 and 24 months after the menarche, has a predictable temporal pattern, and just before menstruation it starts and typically lasts for 8 to 72 hours. It may radiate to the back and thighs and may be accompanied by systemic symptoms like diarrhea, vomiting, as we've already discussed. Now, when you do an examination, a physical examination, there's no lump or no mass, or there is on ultrasonography, you see that there are no pathology is detected, then we label it as primary dysmenorrhea. Next slide, please. So what are the investigations that we generally do? There's a full blood count, the CRP to exclude PID, a high vaginal swab and endocervical swabs to exclude infections such as chlamydia, trachonitis, and Neisseria gonorrhea. CA125 is raised in endometriosis. Of course, it is raised in ovarian tumors, but in endometriosis, it is not as high as it is in ovarian carcinoma. And the pelvis ultrasonography to exclude uterine anomalies, tubo-ovarian abscesses, endometrioma, and hysteroscopy in a married patient to diagnose endometrial polyps and submucous fibroids. Because when these polyps grow and the submucous fibroid tries to expel itself from the os, then there are spasmodic contractions also. Laparoscopy to diagnose minimal endometriosis, pelvic adhesions, and early PID. Next slide, please. So how do we consider the treatment? The first line of therapy is usually NSAIDs like mefenamic acid, and this is the most commonly used one. And the second line therapy is OC pills. Now, what is the, so by OC pills, giving OC pills, we prevent ovulation. And so there is no withdrawal of this progesterone and it suppresses ovulation basically. So management of primary dysmenorrhea is medical management is divided into two. One is NSAIDs and the second one is hormonal. Now, mefenamic acid, 500 milligrams, 8 hourly. Naproxen sodium, 275, 6 hourly. Diclofenac sodium, 75 to 100 milligrams daily. But we should be careful and patient. We should know when to give them. And diclofenac in the patients who have any renal problems, we should not give them. And hormonal therapy, we've already said, it is combined oral contraceptive pills and progesterone containing IUDs like the Mirena. Next slide, please. So what are the drawbacks of existing NSAIDs and OC pills? Before prescribing any drug, we should know what its side effects are, what are the contraindications, in which patients it can be used, and what interactions it has with the other drugs. So gastrointestinal effects are very common with NSAIDs: nausea, vomiting, diarrhea, stomach aches, and serious side effects of stomach ulcers and GI bleeding. Other side effects like headache, drowsiness, dizziness are there. Allergic reactions or hypersensitivity to any drug can be there. NSAIDs are contraindicated in renal insufficiency, peptic ulcer disease, gastritis, GI bleeding, or hypersensitivity. Overall failure rate of 20 to 25% is there, and long-term use is discouraged because of the above mentioned side effects. And OC pills are not approved for dysmenorrhea. OC pills can cause thromboembolism. So in those patients who have a family history of thromboembolism, we should avoid it. Next slide, please. So apart from these, what are the other remedies, the other approaches for dysmenorrhea? We have acupuncture or acupressure, heating pads for cramps, extra bed, rest or sleep, physical exercise. This and meditation can help in many patients. And you have to counsel them that this is a normal physiological event that happens in the life, and this should not be feared. If one person in the family has had dysmenorrhea, it is not essential, it's not a genetic trait that everyone should have it. So ginger root, turmeric extract, pineapple extract, fennel extract, and rosemary. Salt water, calcium and vitamin D3 supplementation. Next slide, please. So now, for the first time, Shield has launched a drug which is called Dismajestic, which has these non-NSAID content in it, and that is called the fennel extract, rosemary leaf extract, and curcumin extract, and pineapple extract tablets. We'll see how they each of them act, what is the mechanism of action. Next slide, please. So Dismajestic action is by antispasmodic activity and anti-inflammatory and analgesic. Next slide. Yes. Now, what is the chemical structure? It contains bromelain. Now, bromelain actually is from the pineapple juice, from the pineapple stems it is extracted. And how does it act? Next slide, please. So we've already seen that the prostaglandins, they are derived from the phospholipase, the membranes of the cell. They contain the phospholipases, and they are acted upon by phospholipase enzyme, which or arachidonic acid is produced by the action of the arachidonic acid cyclooxygenase pathway. Now, the prostaglandin PGE1 and PGI2 are anti-inflammatory. Prostaglandins PGE2, F2, and thromboxane and prostaglandin, the thromboxane A2, are pro-inflammatory prostaglandins. So there is an imbalance between these two. The antispasmodic effect of bromelain acts by inhibiting the arachidonic acid, and thereby you can see in the chain here that the phospholipase A2, that causes the release of arachidonic acid from the cell membrane, and that is again acted upon by this arachidonic acid is acted upon by cyclooxygenase, which converts into the prostaglandins, that is PG2. And here in between, the plasminogen is converted to plasmin. And this action that causes the stimulation of the arachidonic acid, so that is inhibited by bromelain. The cyclooxygenase pathway, that is inhibited by aspirin and the NSAID. So that is how they act. Now, this the thromboxane is converted into the synthetase that causes the conversion of PGH2 to thromboxane A2. This is possibly inhibited by bromelain, and the other pathway which leads to the production of E2 from PGH2 is the endoperoxide pathway, and this again may be inhibited by bromelain. So there is no conversion to PGF2 alpha and less upon the action of the PGI2. So this may increase through the modulation of the PGI2. We have seen is an anti-inflammatory pathway, and that is increased by the anti-inflammatory action of the cytokines, that is the modulation of the cytokine IL-1 and tumor necrosis factor, the interleukin-1. So analgesic effect, decrease pain due to decreased phospholutrine contraction, and anti-inflammatory effect of bromelain by modulation of tumor necrosis factor alpha and interleukins. Next slide, please. So basically for primary dysmenorrhea, 39 female students they had seen, they did a test on age of 15 to 17 years, and this study showed that there were two groups, one in which they received the pineapple juice which contains bromelain, and the other one which had placebo. So in the two, the pain score was seen that it was significantly different, and the p-value was 0.001. So here you can see in the placebo they had 5.64 was the score, whereas in the pineapple juice group it was 2.25. Next slide, please. So the other active ingredient of this tablet is rosemary extract, which contains ursolic acid. That is the active ingredient. Next slide, please. Now, how does this act? Rosemary extract has inhibitory action on COX-2, that is cycloogenase 2 enzyme, Inhibitors of cyclogenase 2 enzyme can reduce the production of prostaglandin, as we've already seen just now. And the mefenamic acid has a similar mechanism of action to reduce pain. By reducing prostaglandins, it can show antispasmodic action and analgesic action. Rosemary extract can reduce the production of IL beta, that is interleukin beta, and tumor necrosis factor alpha. So these have both having an anti-inflammatory action. Next slide, please. Here you can see the mechanism of action again from phospholipase A to arachidonic acid and PGS synthetase, that is the COX-2 pathway, that causes the production of prostaglandin G2, and then to the PGH synthetase, that causes the production of prostaglandin H2, from which you get the G2 and the thromboxane F2 alpha. Thromboxane and F2 alpha. Next slide. And that leads to pain. Now that pathway is interrupted by the rosemary extract. Curcumin, turmeric, that is, we all know the common word for it is haldi, and we use it in all situations, in all foods we use. And whenever a child hurts herself or himself, then if there's nothing at home, people say put some curcumin on it. And because turmeric is derived from curcuma longa and elongates and includes the curcuminoids such as curcumin, dimethoxycurcumin, and bis-methoxycurcumin. It is a member of some regional diets in numerous Indian and Asian cultures. Next slide, please. So curcumin works by modulating the inflammatory response by regulating the activity of cyclogenase, that is COX-2 pathway, lipooxygenase, and nitrite oxygenase, which can, so that it can reduce or even inhibit uterine contractions. The mechanism of blocking uterine contractions through curcumin is by another pathway. It reduces the influx of calcium ions into the calcium canal in the uterine epithelial cells. And we all know that calcium, when it becomes intracellular, it increases the activity of the cells and the contractions. Anti-inflammatory action, that is curcumin, is frequently used with bromelain to improve absorption. Next slide, please. So here we have seen that the conversion of phospholipase A to arachidonic acid, that is by 5-lipooxygenase, and it leads to leukotriene formation. And the other pathway, that is the PGH synthetase, that is blocked by curcumin, and therefore the prostaglandin G2 is reduced, and PGH synthetase, that again leads to the formation of H2, and therefore that leads to the causes the pain through F2 alpha. That is again blocked by curcumin. Now, what are the fennel seeds? So fencone comes from these fennel seeds. The mechanism of action of fennel is similar to diclofenac. The fencone as the main components of fennel that inhibits prostaglandin E2 and reduces the uterine contractions, leading to its antispasmodic effect. Now, anethole as the main components of fennel has a similar structure to dopamine, and this binds therefore to the dopamine receptors and decreases the pain, that is causes analgesia. The anti-inflammatory effect of fennel is due to inhibition of histamines like H1 and H2 receptors, antihistamine like we use in the cough syrup and for cough and cold. Next slide, please. So here you can see where fencone acts. It acts at the PGG2 or PGH2 level, and therefore by blocking it, there is the reduction in the I2 and thromboxane A2. And here you can see by PGD synthetase, the PGD2 and PGF2 alpha form. So there are many types of prostaglandins which are produced. Next slide, please. Effectiveness of fencone versus mefenic acid, that is also studied. And 100% of women had pain before starting the treatment. Now, women received with either fencone or mefenamic acid. So the percentage of women who reported no pain after treatment with fencone was 80% as compared to mefenamic acid. Fencone is as effective as mefenamic acid. Now, in secondary dysmenorrhea, basically it is due to some underlying disease in the pelvic organs, and that is why it is named secondary dysmenorrhea. So what are the usual causes? The gynecological causes that are commonly seen are endometriosis, and this can happen even in adolescents, in very young patients. So we have a tough time treating them because you don't want to do laparoscopy and you do want to save their ovaries. And if the estrogen is there, it is a recurrent condition and it is a progressive degenerative condition. So you cannot take out the ovaries at that age. The fertility has to be preserved. So there are a lot of issues in adolescent patients with endometriosis. Congenital anatomic abnormalities can occur. Sexually transmitted infections can cause this. Pelvic inflammatory disease is quite common. And in these patients of PID, you usually see that they have a history of dysmenorrhea. Adenomyosis, again, another treacherous condition which can occur in any age. And there is severe dysmenorrhea in these patients. So uterine leiomyomas and cervical stenosis, of course. Non-gynecological conditions where there is a high tone pelvic floor dysfunction. Irritable bowel syndrome. Bladder pain syndrome. Bladder pain syndrome is again another distressing condition. And whenever the patient has this condition, you have to differentiate it from other gynecological conditions of low abdominal pain. Pelvic adhesions may lead to it and inflammatory bowel disease. Here you can see that endometriosis from minimal to severe endometriosis and DIE can be there. And that is a very, very distressing condition. And the operation for it through laparoscopy also is not easy because the bowel, the bladder, all of them are adherent to the uterus, the ovaries. There's a thorough anatomical disruption of the normal anatomy. And that is why the operative procedure is also difficult because there are high chances of damaging the ureters, which may be trapped in it, and damaging the bowel. And anteriorly, there may be endometriosis into the bladder also. So these are the spots you can see of endometriotic spots. So diagnosis, that is for evaluating the patient, again, you have to begin with the history, the onset of the symptoms. There may be several years after menarche that these symptoms appear. Recurrent pelvic PID, fever, and vaginal discharge can be there. There may be the presence of an IUCD, which may be the cause. And the recent pelvic surgeries may lead to adhesions, heavy periods, like in adenomyosis, endometrial polyps, and fibroids, infertility, and dyspareunia, as happens in endometriosis. And physical examination may help in the diagnosis and finding abnormalities that point to a pelvic disease, like you may find nodules in the pouch, or it may be very tender on PV examination. Next slide, please. So how do you investigate CBC to rule out anemia? Because in these patients, there is chronic menorrhagia, there may be infection, PID, cervical and vaginal swabs for cultures, as in cases of PID, are essential. Transvaginal ultrasound is the gold standard for this and for the investigation. Pelvic masses may be seen. Uterine fibroids can be seen and polyps very clearly. Pelvic abscess or adenomyosis also can be determined from there. Then laparoscopy, both diagnostic and therapeutic role, it has a therapeutic role also. When you see it, you should be able to treat it also, particularly in the management of endometriosis and where pain is of uncertain origin. Hysteroscopy defines intrauterine pathology and provides an endometrial tissue sample for histology. Next slide, please. So how do you differentiate between the two? The onset, it is in primary dysmenorrhea shortly after menarche, usually 6 to 12 months after menarche and within 3 years. But in secondary dysmenorrhea, it can happen several years after the menarche also. The time it is present during ovulatory cycles and menses only. But in secondary dysmenorrhea may not necessarily be associated with menstruation only. And the age is usually 15 to 25 in primary dysmenorrhea, but it is usually after 25 years. It is secondary, and usually the age is 30 to 45 years. Duration would be 8 to 72 hours during the menses in the primary dysmenorrhea group, but in secondary dysmenorrhea, it is usually of the congestive type, and it is prior to the onset of menses, and it is not relieved with the flow of menstruation. Rather, it happens throughout the menstrual cycle. So what are the symptoms? Here we've seen that back and thigh pain, headache, diarrhea, nausea, vomiting, feeling of bloatedness, all this will be there. And other gynecological symptoms, for example, dyspareunia, menorrhagia may be present in cases of dysmenorrhea, depending on whether it's a case of adenomyosis or there are endometriotic nodules, or there's PID, or there's a fibroid. And pain, that is the lower pelvic or abdominal pain, usually associated with the onset of the menstrual flow, without pathological disease lasting for 8 to 72 hours, whereas in the secondary dysmenorrhea, it may complain of change in time of pain, onset during menstrual cycle, or intensity of pain, and the menstrual pain associated with an underlying pelvic pathology such as endometriosis, PID, and ovarian cysts and fibroids. Aging gradually improves over time, but secondary dysmenorrhea usually gets worse over time. Sexual activity it gradually improves, but here there's no change in the secondary one, rather it may worsen. And the dyspareunia may be there. Postpartum, the primary dysmenorrhea usually improves, but there's no change in secondary because the cause is still over there. Findings of internal examination in primary dysmenorrhea, you may not find any findings. It may be perfectly normal PV examination, but in secondary dysmenorrhea, you may usually get a pelvic abnormality, for example, endometriosis, or the fibroids may be there. The size of the uterus may be big and it may be tender. Dysmenorrhea should, however, not be confused with premenstrual syndrome, which persists with similar symptoms. Premenstrual syndrome symptoms resolve shortly after menstrual flow has begun, and unlike dysmenorrhea, which continues for up to 72 hours. So premenstrual syndrome, that is PMS, that is a group of physical, emotional, and behavioral symptoms that occur in the second half, that is the luteal phase of the menstrual cycle. It often interferes with work and day-to-day activities. Here, the period of symptoms entirely free, starting with menstruation. Next slide, please. So here you can see that the symptoms almost match with primary dysmenorrhea, that is bloated feeling, weight gain, edema may be there, breast pain is very common, and tenderness, hot flushes, headache, nausea, pelvic pain, change in bowel habits, and joint or muscle pain may be there. Emotionally, it includes there's irritability. Next slide. So what are the causes of this? Then it is not definitely known, but there are some theories which suggest that there are various hormone interactions. Vitamin B6 deficiency is there, and that is why in these patients of PMS, we supplement it with vitamin B6, and usually there are psychological causes. Next slide. So the management is counseling and reassurance that symptoms are real, and it could be there, and lifestyle changes actually that helps. Exercise, dietary modifications, exercise for 20 to 30 minutes, increase the endorphins in the brain, distract the women from her emotions. And medically, the symptoms may be bloating, so you give diuretics. Antiprostaglandins may be given, like mefenamic acid for cramp like pain, and breast tenderness may be helped by bromocriptine. Ovulation suppression, OCPs, danazol we do not use nowadays because of its androgenic effects. Medroxyprogesterone acetate continuously, and primrose oil, that may be the primrose oil, that may help a lot. So what is the management pathway for dysmenorrhea? So here we see, according to the symptoms, suspecting dysmenorrhea, you first of all go to the history, then you see that there are no pelvic findings, you may suspect primary dysmenorrhea, and you recommend a non-pharmacological treatment. Now, if that is effective, you continue with it. If it is not effective, then you go over to NSAIDs. And then if that is effective, you continue with it for about 6 months and reassess. If it is not effective, then you go over to the hormonal contraceptive pills. Now, if that is also not effective, then you combine the two and see. So otherwise, you have to look for the causes according to the investigations that we have just narrated. Next slide, please. So the take-home messages are that dysmenorrhea is found to be highly prevalent. Findings suggest family history, bleeding duration, and presence of clots as significant risk factors for dysmenorrhea. Appropriate intervention through a change in lifestyle is always advised, and the barriers to seek medical attention by dysmenorrheic females need exploration. It is important that health education on puberty and menstruation, that is usually regarded inadequate for many young females. And if this is given right from the school, in the school children, that what is menstruation. It is physiological. What is the mechanism, and why there is pain. And most of the time it is because of an unhealthy lifestyle or because of psychological problems. Then they know what is the physiology, and it is a normal event in life, so they take it easily. And this ignorance might adversely affect the medical attention seeking behavior of dysmenorrheic females. So thank you all for a patient hearing and giving your time for this webinar. Thank you, Shield.
Thank you very much, ma'am, for this nice presentation and to discuss a very important topic, that is dysmenorrhea, and which is frequently encountered by the women in their reproductive age. Just give me 1 minute time, ma'am, to check if any question is there.
Sure.
So, ma'am, one question is, during your practical practice, how do you deal with this primary dysmenorrhea? What are the means a line of management you used to prefer in case of a primary dysmenorrheic patient?
Yes, see, when a very young girl comes, 13, 14 years, immediately after menarche, and the mother is so overwhelmed by the pain she has had. So in those patients, you don't generally jump over to OC pills, or you don't generally start investigating, because this is a common phenomena. And in these young girls at menarche, we know that these are usually primary dysmenorrheas. And so first line of treatment is counseling and reassurance that it is absolutely normal. You don't have to take it as a pathological thing. And it happens in many females and girls, and it disappears with your, when you are alert about it, that this is a normal thing. It is not pathological. So don't worry about it. Don't leave going to school, and play with your friends and all. Otherwise, some children, they are just held up in the house. They are not allowed to go and play. So they feel that is something which is pathological. So this has to be eliminated from their minds. But still, even if they come again for it, then the first thing we give is the NSAIDs, and generally it responds to it. Usually, OC pills we do not give in the first group.
Thank you very much.
Your drug, when it will come into the market, I think it will help a lot, being a non-pharmacological stuff. So I think that will help them a lot.
So, ma'am, just one question is, how long can these NSAIDs can be prescribed for continuously? How long period? So, what is your thought on that?
Not to be given for continuous periods. It is not to be prescribed at all for long periods of time, because we know that the patients will then start depending on it. And after, if you use it for continuously for a long time, it has effects on the gastric mucosa. It does cause the renal dysfunction in many patients, especially who are prone to it. We do not advise it at all for continuous use.
So presently, ma'am, is there any other mode of treatment apart from the NSAIDs to treat primary dysmenorrhea?
Yeah, you can advise them for hot fermentation, hot baths, and take a little rest. But basically, it is counseling, and reassurance. And if it does not respond to that, I'm sure your drug will help, because these are.
Thank you very much.
These are non-hormonal stuff.
And that means, ma'am, as we are the one who first time launched in India with a very unique product, that is Dismajestic. So
yeah.
hope that drug will address. Yes, yes, sir. And just one question, ma'am. Last question: that can this primary dysmenorrhea be cured?
Yeah, of course. Of course it can. And many people, many patients, girls, they come after a few cycles, taking 2 or 3 cycles of this NSAIDs and reassurance, they are fine.
So thank you very much, ma'am. So thank you very much, ma'am, for this nice discussion on this dysmenorrhea, which is a very common encounter topic. And thank you very much for focus on our newly launched product also, that is Dismajestic. So we also want that this drug can have some.
Yeah, we should try it. We should try it. Yeah.
Yes. So thank you very much, ma'am.
Yeah.
Thank you very much, ma'am.
Thank you so much for it.
Thank you. Thank you for your valuable time once again in our platform Shield Connect, and in future also we will look forward for some valuable academic session with you. So thank you very much, ma'am.